The theme for this session is Health System for NCDs. The session will be chaired by Professor S.M. Ashrafuzzaman Sir, President Bangladesh Endocrine Society, Dhaka. There are three speakers for the session. They are Dr. Tahnia Haq, Assistant Professor, Department of Endocrinology, Bangabandhu Sheikh Mujib Medical University, and International Affairs Secretary, Bangladesh Endocrine Society, Dhaka, Bangladesh. Dr. Marufa Mustari, Consultant Endocrinologist, Department of Endocrinology, Bangabandhu Sheikh Mujib Medical University, and Office Secretary, Bangladesh Endocrine Society, and Dr. Shahzada Selim Sir, Associate Professor, Department of Endocrinology, Bangabandhu Sheikh Mujib Medical University, and General Secretary, Bangladesh Endocrine Society. The panelists for the sessions are Dr. Farooq Pathan Sir, who is the Chief Patron and Director, Bardem Academy, Bangladesh Endocrine Society, Dhaka, and Professor Hafizur Rahman Sir, Chief Consultant, Endocrinology Department, United Hospital, and President-elect, Bangladesh Endocrine Society. Professor Ashrafuzzaman Sir and Professor Farooq Pathan Sir will join us virtually. Now I request Professor Hafizur Rahman Sir and all the speakers to come to the dais and have their seats. The first session and the first topic will be presented by Dr. Tahnia Haq. The session topic is Risk Factors for Grade 2 and 3 Obesity in Bangladesh, a hospital-based study. Dr. Tahnia Haq will join us virtually for the presentation. Now I request Dr. Tahnia Haq to present her topic.
Thank you. So good afternoon. I'm Dr. Tahnia Haq, and today on behalf of the Bangladesh Endocrine Society, I will be presenting my topic, which is a risk factor of grade 2-3 obesity in Bangladesh, and it is a hospital-based study done in BSMMU. So we know that globally obesity is on an increasing trend, and this is also true for Bangladesh. So there have been a few studies, both national and regional, in Bangladesh, rural and urban areas in children and adults. And in a meta-analysis, it was shown that over 15 years, the full prevalence rate of overweight and obesity was nearly 10%. That is quite high. And you can see from the graph that there is an increasing trend over the last decade. So because of this increasing trend of obesity, we decided to look closely into this problem in our society. So we had a publication before on the cardiometabolic risk factors of overweight and obesity in children in Bangladesh. And our data showed that it was quite alarming that 100% of these children, 88 children with a mean age of 12 years, 100% had central obesity, 70% had metabolic syndrome. Nearly 100% again had dyslipidemia, and about 50% had high blood pressure or insulin resistance. What we found more was that systolic blood pressure and insulin resistance was significantly associated with the grade of obesity. So children with grade 3 obesity had higher blood pressure and more insulin resistance. So we looked further into this problem of insulin resistance. So in another study, in 81 children with a mean age of 12 years, we saw that glucose intolerance based on OGTT and hemoglobin A1C was nearly 15%, so 44.4%. Most of them were pre-diabetic, and a few had diabetes mellitus. So this is a big problem. This is a Google map of the Dhanmondi area recently taken just 2 days back in 2022. So I looked up the parks in the Dhanmondi area. You can see that there's one here, about 4 parks. The lake is here in some green areas. When I Googled restaurants in the same area, you can see almost 14 to 15 restaurants. It's a gross imbalance prevalent in our society. But the good news is obesity is preventable. So based on these previous findings that childhood obesity is rising in Bangladesh, and there's a high prevalence of cardiovascular complications in these obese children, and that severe obesity is associated with greater cardiovascular risk, we decided to look at the risk factors of obesity, especially of severe obesity, in context to our society, in context to our country and our lifestyle, so that we can implement some national prevention guidelines And we focus children at first because this is where it all happens. These children are going to go on to become adults, and obese children will ultimately develop all these cardiovascular diseases, which will bear a burden on our economy. So keeping that in mind, the aim of the study was to determine the risk factors of grade 2-3 obesity in children. It was a simple study done over a period of 1 year. So it was before the COVID era, and it was terminated prematurely actually because of the COVID situation. So we included 189 overweight and obese children, all under 18. After exclusion of secondary obesity based on clinical parameters and basic laboratory tests, for example, endocrinopathies, drug intake, hypothalamic disorders, we included only patients who had primary exogenous obesity. It was an open label structured questionnaire to assess the risk factors taken mainly by one physician. And we divided them into two groups after we got the data. Group 1 consisted of overweight and grade 1 obesity, and group 2 consisted of grade 2-3 obesity, that is more severe obesity. These are the risk factors that we looked at. We divided it into 3 types: the family, activity, and diet. Family factors are parental BMI, education, occupation. Screen time and activity factors were whether they had their own device. Screen time. So screen time was again divided into subcategories. We looked at the screen time, smartphone use other than calling, time on devices like computers, laptops, and tablets for academic and non-academic purpose, and TV watching. Bedtime time at which the child went to bed, when they woke up, if they slept in the day, total duration of sleep in 24 hours, whether they had an access to playground in the school or in their neighborhood, whether they attended coaching and the duration of coaching, and whether they participated in any moderate to physical activity, but we could not actually quantify it. We did not use any minutes. Regarding diet, whether they missed meals, whether they were in the habit of snacking and consuming energy-dense food or eating fruits, whether they were in the habit of eating out, maybe eating out more than 3 times a month, whether they watched media during meals, or where they took their meals in the dining room or elsewhere. So these risk factors were tailored to our lifestyle and society. So factors like having a helping hand, coaching, access to playground, these were included to get a reflection of what was happening in our country. So the results show that there are patients, again, around 12 years of age, mean age, 36% were females. The most common type of obesity was grade 1, closely followed by grade 2 obesity. Like the previous presentations, 81% had dyslipidemia, also in accordance to our previous finding, and glucose intolerance was present in 25%. So again, alarming values. Now let's take a look at the risk factors in children. So 189 children, we saw that the parental BMI was towards the overweight and obese category. It used the Asian cutoff, they were the obese, and the maternal BMI was higher than the paternal BMI. The maximum maternal BMI was 42. The average screen time was 3.5 hours per day. This is a 24-hour screen time of all devices used, and one participant had a maximum screen time of 22 hours. Duration of coaching in 24 hours, again on average 2.5 hours with a maximum duration of 7 hours. So you can see here that screen time and coaching, sedentary lifestyle, in 24 hours, apart from school, they're spending around 6 hours in sedentary work and no physical activity. So look at the frequency of these risk factors. So the maternal obesity, 30% maternal obesity frequency, following up closely behind that. Now this is interesting. You can see here that more than 50% had a screen time of more than 2 hours and attended coaching, and nearly 70% slept after 10 p.m. These are children. Patients, these children, 20% of these children have their own device, and 20% did not have access to any playground, either at school or in the neighborhood. So this is very sad for us. The frequency of diet-related risk factors, again, you can see that 2/3 of these children had bad dietary habits, in the habit of taking fast food. 50% were in the habit of eating out, either taking purchased school lunches or eating out with their families more than 3 times a week. 30% missed their meals, and mostly this was breakfast. They missed their breakfast, and 20% did not take any foods at all. So when we compare the risk factors between the two groups, there were no significant differences, but you can see that the duration of coaching was higher in group 2 than in group 1, although this was not statistically significant, but there was an approach significance. Now we looked at the correlation or relation of the risk factors with the BMI. You can see that coaching and smartphone use, other than calling, they were both related with BMI. So if the duration of coaching increased, or if the duration of smartphone use other than calling increased, so did the BMI. You can see from the chart, however, that the relation was not so strong, the R factor of 0.24, but it was significant. So we went on further to see how much it increases. So we did a linear regression. And here we saw that if the duration of smartphone use increased by 1 hour, then the BMI increased by 0.9 kg per meter square. If the duration of coaching increased by 1 hour, the BMI increased by 0.84 kg per meter square. So that these are alarming figures. There have been few studies on this duration of coaching, because this is, I think, peculiar to our country. But a study in Mauritius showed that children going to schools with a high academic performance, they had a higher BMI. So again, probably because of more time spent studying or screen time and less on physical activity. Again, another study in Sri Lanka showed that students who were giving their grade 5 scholastic examinations, again, had a higher BMI, and it was associated with higher BMI than those who were not. And regard of smartphone use, so screen time, is a big issue. And what's coming up more now is the type of screen time. So is it smartphone, is it computers? And studies have shown that the type of screen time also influences obesity. So it wasn't just the screen time itself, the duration and the sedentary lifestyle itself that was influencing obesity. So specialists think that there are other mechanisms that are also involved, because the type of screen time or the device that they're using also is influencing the amount of obesity. And this was particularly more important in other studies in children who were already obese. So the screen time affected children who were already overweight or already obese more than children who were not yet obese. So we did a multiple linear regression, then taking all factors into consideration, and only duration of coaching was still linearly related with BMI. So that was that stood fast in the statistical analysis. And 12.8% of the variance in BMI was due to the duration of coaching. We ran a logistic regression to look at the risk factors, and we saw that snacking was a risk factor, and presence of snacking increased the risk of severe obesity by around 12 times. Screen time more than 2 hours increased the risk almost by 9 times. Maternal obesity increased the risk by almost 3 times. And screen time by 1.6 times. So these are similar to other studies showing just the risk factor of obesity, but ours was a bit different. We wanted to look at the risk factors of grade 2-3 obesity only. So then we looked at the interrelation of the risk factors. Is one related to the other? So is one influencing the other? So of course, it's quite obvious that if you're spending more time coaching, if you're spending more time on screens, then it's associated with less physical activity. And it was more apparent here in our study, where we saw that the duration of coaching was significantly associated or related with the duration of device used for academic purpose as well as for non-academic purpose. So the R value was quite high. We had a strong association here. Again, the duration of device used for non-academic purpose was again related with the bedtime and duration of sleep, again having a strong R factor of 0.9 and 0.65. So which means that longer the time the child is on a device for non-academic purpose, they're getting less sleep and they're going to bed late. So these factors are all interrelated. In conclusion, there was a high rate of screen time, coaching, and bad dietary habit. The duration of coaching was more in grade 2-3 obesity and was related with BMI, and this was an independent predictor of grade 2-3 obesity. Screen time was a risk factor of grade 2-3 obesity, and duration of smartphone use in particular was related with BMI. Snacking and maternal obesity were also independent predictors of grade 2-3 obesity. So we have to, based on this study, I think it's time to readdress or rearrange our education system to give more importance on extracurricular physical activity. And mind it, this is before the COVID era. So screen time has increased after that. So the picture was probably worse has been probably worse in the last 2 years. So with this, I would like to conclude. I would like to acknowledge my obesity team of the SMMU. We're working together over the last couple of years in management, treatment and management of obese individuals. I would also like to thank NCD for inviting me as a speaker and thanking the audience for their patience hearing. Thank you very much.
Thank you, madam, for your nice presentation. The next topic of the session is women with polycystic ovary syndrome and cardiovascular risk factor. This will be presented by Dr. Marufa Mustari, Consultant Endocrinologist, Department of Endocrinology, BSMMU, and Office Secretary, Bangladesh Endocrine Society. Please, madam.
A very good afternoon, learned audience and chairpersons and panelists of these sessions. Assalamu alaikum. And me, Dr. Marufa Mustari from Bangabandhu Sheikh Mujib Medical University, going to talk on women with polycystic ovary syndrome and cardiovascular disease risk. I'm going to cover the introduction, PCOS phenotypes, cardiovascular disease risk, PCOS and cardiovascular events, assessment of CVD risk, importance of addressing the cardiovascular risk, preventive strategy, and summary. The polycystic ovary is a common endocrinopathy affecting 6 to 10% of reproductive aged women. Clinical manifestation of PCOS include menstrual irregularities, sign of androgen excess, obesity, and sometimes infertility. The clinical manifestations are heterogeneous, and this heterogeneity seems to be adjusted by several factors such as genetic factors, nutritional factors, and parental androgen exposure, insulin resistance, exaggerated hierarchy, and body weight changes. The PCOS pathophysiology is very complex, and the insulin resistance, on the against of insulin resistance, there is hyperinsulinemia, and this leads to ovary to increase more LH. And on the other hand, from the adrenal gland, there is increased dehydroepiandrosterone sulfate, and both these leads to increased androgen. And this increased androgen, after aromatization, there is increased estrogen. So PCOS is a state of increased androgen and estrogen. On the other hand, from the liver, there is increased insulin growth factor binding protein and decreased sex hormone binding globulin. This also leads to increased androgen, and there is also abnormal GnRH secretions. The pathways linking hyperinsulinemia and hyperenergenemia on the background of genes, lifestyles, and upper abdominal obesity, there is increased insulin resistance, which leads to hyperinsulinemia, and hypertension, dyslipidemia, increased cardiovascular disorders. This hyperinsulinemia leads to increased growth hormone binding protein, decreased sex hormone binding globulin. On the other hand, from the pituitary gland, there is increased pulse frequency. And this all leads to increased IGF-1 and free testosterone level, and ultimately there is hyperenergenemia, and which ultimately to increase insulin resistance. So there is a vicious cycle of insulin resistance and hyperenergenemia. There is a different diagnostic criteria, NIH, Rotterdam Consensus, and Androgen Access Society. And because I'm not going through the details, as you know, all these criteria, And there's PCOS phenotypes. There is phenotypes A, B, C, and D. In A, which includes the androgen excess, ovulatory dysfunctions, and polycystic ovarian morphology and sonography. Phenotype B comprises of androgen excess and ovulatory dysfunction. And C, there is androgen excess, polycystic ovarian morphology. And phenotype D, there is ovulatory dysfunction and polycystic ovarian morphology. The PCOS phenotypes and cardiovascular disease risks. Phenotype A is the most prevalent phenotype of PCOS worldwide. And phenotype A and B are more insulin resistant, and higher prevalence of metabolic syndromes are found in phenotype A. The normoandrogenic phenotype D is found to have the lowest prevalence of metabolic syndrome and has mildest metabolic profile. There is this study which is done in Bangladesh, which is published in Human Reproduction journals in 2020. The title was Divergent in Clinical, Anthropometric, Metabolic, and Hormonal Parameter Among Different Phenotypes of Polycystic Ovary Syndrome Presenting in Endocrine Outpatient Department, a multi-center study from Bangladesh. And I am one of the investigators. And in this study, the prevalence of phenotypes A, B, C, and D respectively are 59.2%, 14%, 11.9%, and 14.9%. More than 1/3 of the women had pre-hypertension and hypertension, and 34.1% had abnormal glucose tolerance, 93% had dyslipidemia, and 57% had metabolic syndrome. The hyperenergenic phenotypes, that means A, B, and C, had higher prevalence of pre-hypertension and hypertension, abnormal glucose tolerance, dyslipidemia, and metabolic syndrome compared to the normoandrogenic phenotype D. PCOS and cardiovascular events. There was an increased number of deaths due to complications of diabetes in PCO group, but there was no increased death from cardiovascular-related causes in some studies showed. Type 2 diabetes, myocardial infarction, stroke, which are the leading causes of death in women with PCO. And in a cohort of women with proven coronary artery disease, which was done on 143 PCOS women aged less than 60 years, showed PCO were noted in 42% of the women. Additionally, their presence was associated with more severe coronary stenosis of more than 50% with PCO compared with normal ovaries. In women with PCOS, fourfold increased risk of type 2 diabetes, up to fourfold increased risk of non-alcoholic fatty liver disease, and twofold increased risk of coronary artery disease, stroke related to control, and higher risk persists after correction of body mass index. Long-term data are lacking regarding morbidity and mortality due to cardiovascular disease. Assessment of cardiovascular risk, overweight or obesity. Obesity, one of the major modifiable risk factors for cardiometabolic disease. 50% of the women with PCOS are obese. Both obesity and PCOS are linked to a higher metabolic and cardiovascular disease risk, but there is conflicting evidence of independent associations. Dyslipidemia, women with PCOS have lower high-density lipoprotein cholesterol, higher triglyceride. Low-density lipoprotein cholesterol and non-HDL cholesterol levels are high even after BMI matching. Lean women with PCOS have a high prevalence of dyslipidemia controlled to a lean control. Hypertension, high prevalence of pre-hypertension and hypertension in PCOS. Obesity is expected to exacerbate the risk of hypertension in PCOS. Lean PCOS also have higher prevalence of hypertension. Abnormal glucose tolerance. The prevalence of IGT and type 2 diabetes are greater in PCOS compared with non-affected women independent of BMI. Factors associated with abnormal glucose tolerance include PCOS status, increased age, obesity, central obesity, testosterone level, family history of type 2 diabetes, and pregnancy. Insulin resistance and hyperenergenism. The two cardinal features of PCOS are insulin resistance and hyperenergenism, and they are present in PCOS independently of body weight. They are exacerbated by obesity, especially visceral and central obesity. Insulin resistance is present in 75% of the lean and 95% of obese women with PCOS. The hyperenergenism is present in 60% of lean and 80% of obese women with PCOS. Weight loss reduces abdominal fat and in insulin resistance and improves menstrual functions and hyperandrogenism. Women with hyperenergenic PCOS have a worse cardiometabolic profile and higher prevalence of cardiovascular risk factors compared to women with non-hyperenergenic PCOS. This is the figure showing the risks, the hormonal changes. In polycystic ovary syndrome, there is insulin resistance, hyperinsulinemia, and hyperenergenism, which leads to obesity. On the other hand, obesity also increases the insulin resistance and hyperenergenism. The traditional risk factors: central obesity, dyslipidemia, hypertension, and impaired glucose tolerance. And this leads to hyperenergenism, sympathetic nervous system dysfunctions, chronic inflammation, oxidative stress, hemostasis and fibrinolysis imbalance, vitamin D deficiency, mood disorders, gut microbiota disorders, and epigenetic alterations. So there is premature atherosclerosis, endothelial dysfunction, intimal media thickness, and coronary artery claudications. So all this leads to non-alcoholic fatty liver disease, type 2 diabetes, coronary heart disease, and stroke. The risk factors, as I have already mentioned, the traditional risk factors, the central obesity, hypertension, dyslipidemia, and impaired glucose tolerance. There are also some non-traditional risk factors like hyperenergenism, sympathetic nervous system dysfunctions, chronic inflammations, and which is manifested as increased C-reactive protein, increased adiponectin, omentin, homocysteine, and etc. Oxidative stress is increased, and which is manifested as increased homocysteine, increased asymptomatic diamylinar arginine, and homeostasis and fibrinolysis imbalance, and which is evidenced by increased fibrinogen activator inhibitors 1, increased plasminogen, and increased lipoprotein. Vitamin D deficiency, mood disorders, and dysbiosis of gut microbiome. The importance of addressing the cardiovascular risk in PCOS patient. In PCOS patient, there is severe depression and mood disorders, and these are the independent risk factors for cardiovascular disease. This also impaired the quality of life from body image. Concerns cause are fatigue, sleep disturbance, phobia, appetite changes, and binge eating. Depressed women with PCOS have higher BMI and greater insulin resistance as cardiovascular disease risk factors than non-depressed women with PCOS without differences in androgen excess. Weight loss through an energy-restricted diet improves their depression and quality of life. So preventive strategy, lifestyle modifications as first-line therapy for safety, public health benefit, and avoidance of risks and side effects of drug use. For overweight and obese women with PCOS, lifestyle modification can be used to reduce CVD risk, which including proper diet, exercise, smoking cessation, and behavioral techniques. Short-term weight loss intervention in PCOS women decreases abdominal fat, reduces androgenicity and insulin resistance. It also improves dyslipidemia, improves depression and quality of life. In two large intervention studies, almost 60% relative risk reduction in conversion to diabetes mellitus occurred in obese individuals with IGT. Intensive lifestyle modification is needed to reduce body weight by 5 to 7%. 5 to 10% weight loss is necessary to reduce obesity-related cardiovascular disease risk factors, with long-term goal of achieving and maintaining reduced weight of 10 to 20% and a waist circumference of less than 88 to 80 centimeter, depending on ethnicity. Screening for premature cardiovascular disease is important before initiating exercise, and successful lifestyle management requires self-esteem and motivation. Validated tools for screening, treating, and monitoring depression, abnormal eating patterns, and reduced life quality may be necessary. So as a last, the summary, polycystic ovary syndrome should be considered a significant risk factor for cardiovascular disease regardless of BMI. Early diagnosis of PCOS has great and undeniable importance. The phenotype of PCOS should be taken into consideration when assessing cardiovascular disease risks. Lifestyle modification should be encouraged for all women with PCOS for CVD preventions. Thank you. Thank you, Bangladesh Endocrine Society and organizers to give me the opportunity to give my delivery here. Thank you.
Thank you, madam, for your elaborate presentation. The next topic will be presented by Dr. Shahzada Selim sir, who is currently acting as Associate Professor, Department of Endocrinology, BSMMU, and he is the General Secretary of Bangladesh Endocrine Society. His topic is Bangladesh Endocrine Society's position statement for management of diabetes mellitus and other endocrine diseases in patients with COVID-19. I request sir to present.
Thank you, Dr. Faisal, for the kind introduction. Honorable Chairperson, the President of Bangladesh Endocrine Society, Professor S.M. Ashrafuzzaman, he is connected virtually. The learned panels, Professor Muhammad Farooq Patan sir, the mentor of my endocrine field, and the President-elect, Professor Muhammad Hafizur Rahman, he is physically present here. So we are grateful to the persons who are present in person. By previous two speakers, Dr. Tahania Haq and Dr. Marufa Mustari, and the learned audience, on behalf of Bangladesh Endocrine Society, we express our gratitude to the conference organizer for giving us the scope to speak. My topic is Bangladesh Endocrine Society, position statement for management of diabetes and other endocrine diseases in patients with COVID-19. This is the presentation published in the journal. You can see the diabetes, metabolic syndrome, obesity, targets and therapy. This is one of the most important journal in the field of endocrine diseases with very high impact factor. I can assure that from Bangladesh, no other organization could publish any guideline or position statement in such a high impact journal. So we are very much proud as an endocrinologist in Bangladesh. I worked as the member secretary of the guideline committee headed by Professor Farooq Patan sir, Professor Fariduddin, Professor Hafizur Rahman, S.M. Ashrafuzzaman, Faria Afsana, Nazmul Kabir Qureshi, Tanjina Hussain, M. Saifuddin, ABM Kamrul Hassan, and Ahmed Salam Mir. So again, my gratitude to all the contributors of the guideline. We very well know that we are passing through the COVID pandemic, and we are again in the third wave. A huge death toll with very number of new cases, and the prevalence is very high even in Bangladesh along with other countries. The COVID-19, the unprecedented infection posed the world in a very challenging situation. The healthcare professionals, the healthcare authority, the financial and other authorities all are in the challenging mode. But the patients who are having endocrine disorder, especially diabetes mellitus, has special consideration to have a special treatment policy, because several publications from different countries show that the patients who are having diabetes, they have at least 1.3 to 2.3% increased death toll. But the patient with poor control of diabetes, at least 4 to 5 times higher mortality are present among them. One Korean study showed that the patient who are having high glycemic variability, blood sugar is going down, immediately it is going up. Among them, the mortality may up to 9.3 times comparing with the non-diabetes population. So, from Bangladesh, even from Bangabandhu Sheikh Mujib Medical University, our ICU findings suggest that around 60% patients who are admitted with severe condition, COVID condition, they have diabetes. Among the patients who had the mortality rate around 44% had diabetes. So the patients with diabetes who are infected with COVID-19, they should be in the special population group. Not only diabetes, some other endocrine disorders also should be considered. That's why Bangladesh Endocrine Society, as the commitment to the community, they formulated this position statement and published in good quality journal. Now coming to the guideline. Glycemic target. For every patient with diabetes, there should be an individualized glycemic target that is expressed usually in the HbA1c level or maybe SMBG. But HbA1c is a more beautiful one. But for patients who are having acute infection, for those patients, SMBG, self-monitoring of blood glucose by glucometer or other method is more important, because HbA1c is a reflection of 3 to 4 months of previous diabetes duration. But for hospitalized patient or patient with COVID-19, the real-time records are needed. So the patients who are having HbA1c less than 7%, they are in a good glycemic control status. Patients who are having less than 8% with comorbidities, they are also have increased chances of morbidity and mortality. But if we categorize the patient to have target strict control, the fasting blood sugar should be 4.4 to 6.1 millimole per liter, and 2-hour postprandial 6.1 to 7.8 millimole per liter. Medium control 6.1 to 7.8 millimole per liter, and 2 hours postprandial for the interruption. And 2 hour postprandial for medium control group 7.8 to 10 millimole per liter. Low control or poor control fasting blood sugar 7.8 to 10, and 2 hour postprandial 7.8 to 13.9 millimole per liter. So the patient who are having no comorbidities or young or otherwise they are of good quality health status, for those patients strict control is warranted. But for patient of elderly age or the patient with other comorbidities, a medium or low target can be practiced. So hypoglycemia is generally considered blood sugar 3.9 millimole per liter or less is a condition of hypoglycemia. The continuous glucose monitoring or flash glucose monitoring, it is not usually practiced in Bangladesh. Very few number of patients, especially with type 1 diabetes mellitus, they are using this continuous glucose monitoring pump, and in the pump usually there is inbuilt continuous glucose monitoring system. Self-monitoring of blood glucose, I am repeating this word because most of the patients who are with diabetes are living at home, and they will practice blood sugar monitoring at their own. This is self-monitoring of blood sugar, and this record will reflect at the end when we measure HbA1c. Now, how many times a patient with diabetes should measure their blood sugar? The patient who are having, who are on sulfonylurea or maglidazide, these are the oral drugs, they can have 4 times blood sugar, 1 fasting and 3 times 2 hours after breakfast, 2 hours after lunch and 2 hours after dinner. But the patient who are having, who are on insulin with other OADs, the more frequent blood sugar monitoring can be needed, but at least 4 times blood sugar should be practiced there. The patient who are having diabetes and who are pregnant, the pregnant lady, they should have blood sugar monitoring repeatedly, at least 6 times daily. And for type 1 diabetes mellitus, again, around 6 times blood sugar should be monitored. So nutrition management and physical activity in COVID-19 patient. You all know the patients with diabetes mellitus depend on the diet, good quality diet for having good glycemic control. Probably in the world, the only one disease that is directly related to the diet of the patient. So patient with COVID-19 positivity, they have anorexia, nausea, vomiting, or in other conditions they cannot take adequate food. So the patient should encourage to have good quality foods. But the condition that can hamper their eating pattern, that is gastrointestinal symptoms like anorexia, nausea, diarrhea, vomiting, dehydration, irregular meals, lack of care in isolation ward, stress, anxiety, and anosmia. This time we are not encountering the patients, they are complaining that they have anosmia, but the last wave, many of the patients came out with the symptoms of anosmia. The patients with COVID-19, many of the patients may have dehydration, and the patient with very high blood sugar, again, the hyperglycemia can cause dehydration. And dehydration with very high blood sugar can cause diabetic ketoacidosis. So patients with COVID-19 should encourage to consume profuse water and other fluids as possible. But the patient with very high blood sugar should consume water and non-sweetened beverage. So the drinks like sherbet or cool drinks should be discouraged. The protein energy balance, the previous session discussed about the malnutrition led by Dr. Alia Nahid. The main problem in Bangladesh is very high carbohydrate consumption with relative less protein. One study found that in the globe, Bangladeshi population consume least amount of protein per day. So the cause of diabetes, cause of cardiovascular diseases and dyslipidemia may be due to sarcopenic obesity. We do not have a very big structure, but with large protein fat mass comparing with the body mass. So again, the patient with COVID-19 with diabetes, they should be encouraged to take profuse protein diet comparing with the carbohydrate and other lipid diets. Vitamins and minerals, this is again very important to talk about. Many of the authorities, though they did not have any good quality study at their hand, but advocated to go for supplementation with vitamin D. But zinc and vitamin C, some authorities are in favor, but others are not. Physical activity, all the patients with diabetes are encouraged to perform physical activity, and this is again, it is customized. But during this COVID pandemic, all patients with diabetes are encouraged to be at home as much as possible. So how they can perform physical activity? With this limitation, they should perform physical activity at their home. Whatever method can be applied, like they can go for treadmill or exercise cycle, they can use their garage or rooftop area, even they can use the stairs. But the message is very clear, the patient should perform physical activity, and this can be again consulted with the physician and customized. Now the diabetes mellitus management in COVID-19 patients, who can be treated at home. The message is very clear. The patient who are having mild symptoms with good quality of diabetes control with very few of other comorbidities, that can be treated at home. But the patient who are having moderate to severe COVID with other comorbidities or very high blood sugar, like blood sugar more than 11 millimole per liter in repeated measurement, they should be transferred to hospital. The patient who have ketone in urine, vomiting or diarrhea, they should also be transferred to hospital. The patient who cannot take their food, they can also be transferred to the hospital. Weight loss of more than 2.5 kg during this illness, again indication of hospital transferation. Rapid breathing, abdominal pain, reduced level of consciousness, the group of patients also should be transferred to hospital. Coexisting serious morbidities like symptoms of cardiovascular diseases, they should also be transferred to the hospital. And clinical features of moderate, severe and critical COVID-19 patients should get hospitalized. Now, how we can treat the patient with COVID-19 and diabetes mellitus? The novel one, the metformin should be stopped if severely or critically ill with hypoxia, acute GI symptoms of dehydration. But this should be stopped for a very limited time, for a few days, even for a few weeks, because metformin also can cause anorexia, nausea, vomiting. Sulfonylurea drugs, if these are capable of maintaining good quality of glycemic control, that can be continued. But many of the patients with moderate to severe COVID-19, they will have very high blood sugar, and they should be transferred to insulin. SGLT2 inhibitor, beautiful drugs, but most of the patients with COVID-19, especially moderate to severe COVID-19, SGLT2 inhibitor should not be given. GLP-1 receptor agonist stop if acute GI symptoms, gastrointestinal symptoms are present. DPP-4 inhibitors can be continued if patient can tolerate or good glycemic control can be maintained. Pioglitazone can be continued. The insulin is the most reliable resort of managing any patient, not only in COVID-19, in any acute patients or critical patients. This is the insulin. Now, if we consider the treatment according to patient COVID-19 categorization, the mild patients, they can continue the previous drug. If with this drug, we can maintain good glycemia. The moderate patient, if the good glycemic control with the previous drug can be maintained, can be continued, but many of the patients will require insulin. For severe patients or critical patients, insulin is the last resort. But many of the patients are getting steroids for their COVID-19 management, and for those patients, insulin will be required. Now, insulin initiation from OAD, I told that many of the patients with moderate to COVID or severe COVID, they will require insulin. See, the beautiful insulin is the basal bolus regimen, the one long-acting insulin with 3 times bolus insulin, but few other options can be given. But in the hospitalized setting, if possible, the insulin pump can be practiced. This is better than insulin, basal bolus insulin regimen. Split mix insulin, many of the countries usually do not practice, but in Bangladesh and other parts like Bangladesh, we are using the split mix insulin. This can be practiced if the patient with moderate to COVID-19 patient. Premix insulin can be given, but usually it is not as much as good as basal bolus insulin. Co-formulated insulin also can be given, and basal bolus insulin regimen is the beautiful one. The half of the basal insulin, the long-acting insulin, and half of the bolus insulin, this is given usually 3 times a day. It can be given to the patient for the good glycemic control. We had a long debate. The patients with diabetes who are treated for their hypertension with AC inhibitor, ARB, should be given. At the end, the European Society of Cardiology came with the statement that the patients who are receiving AC inhibitor and ARB, it should be continued. Aspirin, again, one of the magic drug, should we give in the patient with COVID-19? If there is no contraindication of using the aspirin, we can continue it. Statins, again, if there is no contraindication, we can continue. Lifestyle therapy is the beautiful option for the patient with COVID-19, but it again should be individualized. Hospital setting, many of the patients will get hospitalized, and most of the hospitals, the patients who are getting coming to their hospital service, many of the patients should go to the ICU. And again, the number with the diabetes is the highest number. So, other than face-to-face hospital service, where it should be newly diagnosed type 1 diabetes mellitus, severe hyperglycemia requiring insulin, this is not for inpatient, it's an outpatient service. Teaching blood glucose monitoring in urgent situation as pregnancy, or educating about continuous glucose monitoring. When blood test monitoring is needed, urgent physical examination is required, like fourth problem of diabetes mellitus. We can again look for the virtual, these are done by telephone, video or email. We had vigorous discussion in previous session. For the follow-up of the newly diagnosed patient with type 1 diabetes, vulnerable patient as history of recent hospitalization, recurrent severe hyperglycemia, HbA1c more than 11%, diabetes follow-up, insulin dose adjustment in pregnancy, and risk for face-to-face appointment is greater than the benefit. For those patients, virtual consultation is advocated. Who should not come to hospital during this COVID pandemic? The stable and well-managed diabetes patient, risk of attending OPD is greater than the benefit. Almost all patients have the greater risk than the benefit. Then health education sessions are stopped in probably all hospitals during this COVID pandemic. Who should get hospitalization? Again, subcutaneous insulin is reasonable for most general and surgical patients outside the ICU. Insulin analog We are currently using insulin analog in most of the cases. Basal insulin, I told that basal bolus insulin is a beautiful one. In Bangladesh, many of the settings are using the sliding scale insulin. Not only Bangladesh Endocrine Society, all authorities are strongly discouraging the using of sliding scale insulin in hospitalized setting. Fluid management, I am not going in details, but for the patients with diabetes who are having the renal dysfunction, cardiovascular dysfunction, considering all, judicious use of fluid is needed. That will save the life of the patient. And again, insulin, as much as insulin use can be used, that will again for beneficial for the patient. Potassium replacement for many patients it will not be needed, but for few patients it can be needed. But blood sugar monitoring is crucial for every patient. COVID-19 infection in people without previously recognized diabetes increase the risk of the emergency state of hyperglycemia with ketones. Diabetic ketoacidosis and hyperosmolar hyperglycemic state, it requires adjustment to standard approaches to diabetes management accordingly. And one important message, this may be similar for several countries. The total patients with diabetes mellitus getting hospitalization for COVID-19, around 1% have new onset diabetes. Now diabetes management after recovery from the COVID-19, patient will go up with the discharge certificate and they will maintain the drugs, and at least 1 week they will be isolated, and then they will go for their work, but they should be follow up accordingly. Now, prevention of COVID-19 in people with diabetes, general precautions, this is for all people, but for the specific situation, patient with other comorbidities, pregnancy, they should be encouraged to practice the optimal precaution for keeping themselves away from COVID-19. Now, pregnancy and diabetes, again, area of debate. But now we have the strong guidelines. The pregnant women experience immunologic and physiologic changes which might make them more susceptible to viral respiratory infection, including COVID-19. There have been cases of pregnancy loss, miscarriage, and stillbirth in women with SARS coronavirus and MERS coronavirus during pregnancy. We have a series of case reports for our Bangabandhu Sheikh Mujib Medical University. They found also increased risk of miscarriage among patients with COVID-19. It's important to note that high fever, one of the symptoms of COVID-19 during the first trimester, can cause or increase the risk of birth defects. So the patient who had diabetes prior to COVID-19 and they have conceived, they should be monitored accordingly, and insulin should be given, and the monitoring should be enhanced, and if possible, they should be at their home. Now, one changes that has been made from other authorities, that the standard diagnostic test for COVID-19 for pregnancy should differ during this COVID-19, because the patient should not go to the centers frequently. We can use HbA1c or random blood sugar, and though these are not practiced in other situations. Management of DDM, all the patients with gestational diabetes mellitus, the lifestyle modification is the first option. This is diet and physical activity. Next to diet and physical activity, insulin should be started. Again, I may like to make it clear, no other drugs other than insulin can be started whenever the patient has diagnosis of gestational diabetes mellitus. Now, healthcare professionals and diabetes. This is very important or some information for the physician and other healthcare professionals in Bangladesh. Globally, the number of healthcare professional mortality is highest in Bangladesh, comparing all the countries of the world. So they should be practiced. The authority should take care of their personnel so that they can confer good quality service to their nation. Now, management of endocrine diseases during COVID-19 pandemic, this is other than diabetes. Adrenal insufficiency, very important, though not the number is very high. The studies have reported that individuals with adrenal insufficiency have an increased rate of respiratory infection-related death, possibly due to impaired immune function. After diagnosis of COVID-19, a prompt modification of the replacement dose is indicated for the 6 days rules, and the patient again should be warned. The facility should be promptly employed for optimal support of the patient. Even then, the patient has the high chance of mortality. Cushing syndrome, again, the patients who are having Cushing syndrome diagnosis prior to COVID-19 or during this time, they should be treated accordingly so that the outcome might be better. Thyroid diseases, the COVID-19 probably is not related to hypothyroidism, but there are several reports or study finding that it can increase the chances of subacute thyroiditis or thyroiditis that can cause in the long run hyperglycemia or many of the cases hypoglycemia. So the patients who are coming with the symptoms of COVID-like features, or they can be addressed with the symptoms of subacute thyroiditis appropriately thus, and appropriate treatment should be given to those patients. Thank you all. This is very brief summary of because it's very long guideline. If you have any question, we can come out with the answer. Thank you for the kind hearing. And if you can have the question to other speakers, we can respond to your questions again.
Thank you, sir, for your nice and elaborate presentation of the guideline. Now it is time for open discussion and question and answer. I request Professor Hafizur Rahman, sir, to conduct the session. Sir, please.
Dear participants, Assalamu alaikum. So now it is the time for question and answer session. So if you have any question, you can ask to our 3 presenters, or there are panelists also. I am also on a panelist, and Professor Farooq Patan sir also in online. So if you have any question or any comment, you can give. Okay, I think, madam, please.
Thank you, sir. It was a really fascinating learning from this session, and a very important one, and rightly placed in this program in the pandemic of COVID. I'm just curious to know, to learn a very different thing. So there is we are working with a very low education people. Lot of them had a perception that people having diabetes should not avoid sugar totally. So they think that the sugar can also help controlling diabetes to some extent. And that was a myth. But in our studies, one of the studies that's very interesting, that we found that those who actually take moderate amount of sugar on a systematic way in their diet, apart from those who who completely avoid sugar, there are better control for them who have balanced sugar intake in their daily food. So this is a puzzle for us. So I'm very happy to ask this question to this learned audience. Do you think intake of sugar has any role in controlling glycemia in diabetic patient?
This is very brilliant questions. Thank you, Aliapa. And many of the participants and other people like to think that is glucose as having any relationship with diabetes onset. A few data I cite first. One study published last year in the April and published in Diabetes Care, the highest impact journal in the field of diabetes. They found that Bangladeshi population with diabetes consume in total 70 to 80% daily calorie from carbohydrate, and the recommendation is 55 to 60. And another study found that the Bangladeshi population without diabetes, they consume 80 to 90% calorie from carbohydrate per day. Recommendation is 40 to 50%. So previously I told that the main cause of cardiovascular disease, hypertension, diabetes, dyslipidemia is the high carbohydrate in relation to low protein. So reducing the carbohydrate cannot improve the quality. This should be balanced. The one detrimental approach has been observed that the patients are going for keto diet. They are dramatically reducing the carbohydrate content, increasing the protein content. Increasing protein content cannot save the patient. Again, this is very much detrimental because studies published in Lancet, 12-year follow-up study, they found that they are who are consuming less than 5% carbohydrate per day, they observed around 54% cardiovascular death, 32% cancer increase rate, and overall mortality rate increased by 34%. So there should be balance of carbohydrate consumption, protein consumption, and one study we published in Mohammed Medical College Journal that one of the risk factor of cardiovascular disease in Bangladesh is less fruit intake. We are taking seasonal fruits for 1 month, 2 months, 3 months, and other months we are not consuming fruits. Everything should be incorporated. Two other things should be included. We are consuming large amount of salt per day and fresh sugar, the refined sugar, in the form of any sweet or other things. So a good quality approach, the non-communicable disease conference can end up with this one, that how much sugar, how much protein, how much vegetable and fruits can be consumed each day. Thank you for the question.
Can I answer some of the part of the question asked by the Dr. Alia? It should be clear, the message, the refined sugar should be avoided because, as you know, in diabetic patients, fasting and post-load insulin delivery system is not good and defective. So if you load the patient with the refined sugar, which is a high carbohydrate load, might not enough to cope with the insulin secretion from the beta cells. So complex carbohydrate with high fiber content carbohydrate, which absorb the glucose very slowly, is better for not to give an insult to the beta cell. That's why good glycemic controls to achieve the good glycemic control for fasting and post meal, we should take the carbohydrate content, which is the low glycemic index, low carb load, would help the patient as a lifestyle modification to maintain the good glycemic control, rather than not to use the refined sugar at all.
Assalamu alaikum. I'm Dr. Fariha Hassin. I'm working in Department of Public Health and Informatics, Bangabandhu Sheikh Mujibur University. All the presentations were very interesting. One of the presentation draw my attention, that is women with PCOS and CVD risk. I think it's very, very important. And in your presentation, Dr. Marufa, you have recommended some preventive strategies. So far I remember, one you said about the proper diet, another one is lifestyle modification, and another terminology I really liked, that one is a successful lifestyle management. So would you please explain but what do we mean by proper diet for the PCOS woman, and also how we can modify our lifestyle successfully? Thank you so much.
Thank you for your question. Actually, lifestyle modification include the proper diet. It should be individualized. It depends upon individual lifestyle. If she is sedentary worker or not, her comorbid conditions, and above all conditions, we have to offer the individualist dietary pattern. And regarding the exercise, it is also depends upon the individualized habit and comorbid conditions.
Thank you, madam. Actually, I also want to another things, that is diet, exercise, and another one, because we have seen from the presentation of Dr. Tanya that rest is also very important. Adequate sleep, that should be also included as a part of our lifestyle modification.
Can I add something here? As the case is PCOS, if you go the background of PCOS, the most important part of the modifying factor to development PCOS is the unhealthy lifestyle. So the most important treatment of the PCOS, management of PCOS, is to recover or go back to healthy lifestyle. If you recollect the healthy lifestyle, the two things is important. One is balanced diet, which is applicable whether you are suffering from any disease, diabetes or PCOS or not. every person to have a good health need a balanced diet according to WHO formula. So here also we have to prescribe the WHO formula and the diet plan according to physical activity, according to the obesity, general obesity, according to dietary habit. We have to always think about the balanced diet on that individual patient. And the physical activity is also important. So lifestyle modification include the dietary and the planned dietary habit according to WHO balanced diet plan and the increased physical activity. Those two important points, if we can remember, we can also maintain good treatment for the PCOS rather than giving any drugs.
Any other question?
Can I make a comment? I am online.
Yes.
I'm Professor Firdousi Begum, President of OGSB, and my field of work includes PCOS as well. I think I'd request the presenter and maybe learned person like Farooq Pathan Bhai and Ashrafuzzaman that we may prescribe or may advise regarding the lifestyle modification, but it's very difficult to implement this in the lives of especially the adolescents who suffer. So I think we need to work on this, but can we get some highlights from you people, experienced people, that how can we implement this? Because we advise the people doesn't follow this. Thank you.
Okay, Professor Firdousi Begum, I'm highlighting the important issue about the management of PCOS. Usually what should be done? You have to explain the whole thing to the patient and her parents about the disease pattern, how it is occurred, and counsel the patient how we can improve your disease defect, what you have already done for your unhealthy lifestyle. So counseling, I think, is the most important point to motivate the patient and to adhere the patient on the advice what you are giving. So if you give some medication, they always think the medication will improve our PCOS case. If PCOS is not improved, it is under control. You have to, like diabetic, you have to maintain good glycemic control. It is important to maintain. So here also, if you can maintain the healthy lifestyle, you also can control your PCOS also. And not only that, by maintaining a good lifestyle, you can also reduce the other risk factor or cardiometabolic factor which is associated to PCOS. PCOS is one of the part of the non-communicable disease spectrum. The disease spectrum, you have to reduce the risk factor of disease spectrum. You can also reduce the cardiovascular mortality and metabolic morbidity of a PCOS case. So PCOS is nothing but a combination of non-communicable disease spectrum plus reproductive abnormality. That's the most important part. Reproductive abnormality you can reduce if you can maintain the healthy lifestyle. In also the PCOS case, it is not a separate thing if you compare the other NCDs risk factors like hypertension, obesity, dyslipidemia. This is also another part. This is also another part of the NCDs. So if you reduce the NCDs incidence, prevalence in PCOS case, you have to go in background details about the cause and the process is a modifiable cause. So if you make the modifiable cause under control, you can also control the PCOS case, and you can also prevent the PCOS case. Whose family PCOS is found to be a higher risk to develop PCOS in the children, you can also prevent PCOS if you can maintain the good healthy lifestyle.
Thank you, sir.
Thank you for that.
Thank you. Actually, we are running short of time because we have to conclude this session within few minutes. Honorable Chairperson of this session, Professor S.M. Ashrafuzzaman, and learned speakers, Dr. Tahania Haq, Dr. Marufa Mustari, Dr. Shahzada Selim, and distinguished panelist, Professor Farooq Pathan sir, and moderators of this program, Dr. Chaudhry Faisal Muhammad Manjur and Dr. Muhammad Sohail Rana, and reporter of this program, Dr. Tahmina Hussain, and distinguished participants. Assalamu alaikum. Thanks everybody for arranging this program and inviting me as a panelist. Actually, today we have 3 speakers, and in the first topic, if you see the presentation of Dr. Tahania Haq, it was an excellent presentation. And in our practice as a clinician, we see that in our chambers also, that is these adolescent girls, they're coming. And we see that in many cases, they are not only developing this type of obese patients, they are not only developing diabetes, they are not only developing dyslipidemia, also we have seen that there is polycystic ovary syndrome, and also I have seen that many cases they are developing non-alcoholic fatty liver disease. So it is very important to address the issues, what is the responsible to become obese in this growing age people, and then we have to address that issues. And also there is another, the next topic, Dr. Marafi Mustari, he has also addressed about the PCOS and the associated risk of cardiovascular disease. And we have seen that there is no, yes, polycystic ovary syndrome in associated with certain metabolic disorders like diabetes mellitus, like dyslipidemia, like hypertension, and all are risk factors of cardiovascular disease. But there are, in the long-term studies, it is not well established that always it increases mortality and morbidity. There is a 30-year trial where it was seen that it is the patients who have done waist resection for polycystic ovary syndrome, in some cases there is increased risk of mortality, but in not all cases. In nurses' health study, where they have irregular menstruation, in that case also, in some cases there is increased risk of mortality, but in other cases it is not. Also, we know that in polycystic ovary syndrome, there is increased C-reactive protein, endothelial dysfunction, increased coronary intermedial thickness. These are all risk factors. But in conclusion, that yes, we have to search for cardiovascular. If patient has polycystic ovary syndrome, we have to search for this cardiovascular risk factor, and we have to address. And regarding Dr. Shahzada Selim, we know that this is the consensus estimate of Bangladesh Endocrine Society. Dr. Shahzada Selim has in details described about this. So, because actually it is a guideline for our general practitioners, and this guideline was made at the very early stage when COVID-19 affected the whole world. But now also, because we are now coping with this, and also we are managing these COVID-19 patients in a better way. So now I think our chairperson, Dr. S.M. Ashrafuzzaman, I think is in line.
Thank you very much, Dr. My dear friend and colleague, Professor Hafizur Rahman, President-elect Bangladesh Endocrine Society. Indeed, it's my great pleasure to be part of first National NCD Conference 2022, which is organized by eminence and other stakeholders like ICDDRB, NCDC, BNCDF, and Health Reporters Forum, as well as Clinical Research Foundations of Bangladesh. I am really delighted to be to chair such a wonderful session, which is presented by Bangladesh Endocrine Society, and three eminent speakers with their beautiful papers, and one of his positional statement from Bangladesh Endocrine Society, which is already published in a very renowned peer-reviewed journal and very good impact factor of this journal. In this respect, I'd like to thank again Dr. Shahzada Selim, who has made successful to be Bangladesh Endocrine Society to be part of first NCD National Conference, and he has taken the maximum initiative or the foremost initiative to participate by the Bangladesh Endocrine Society to be in this national NCD program. NCD is one of the seed in same soil. Most of the NCDs, except in COPD, asthma, and cancer, because diabetes, hypertension, dyslipidemia, coronary artery disease, metabolic syndrome, PCOS, non-alcoholic fatty liver disease, coronary artery disease, and some of the cancers are starts from same seed or same soil. Insulin resistance starts from here. Obesity is the key factor, along with some genetic influence, to be the primary component for these diseases of NCDs. NCDs cover most of these diseases, and we have to prevent it. As we have Dr. Tania already shown, a large number of students in preschool and school-going children are getting obese, about 20 to 40%. So it is very much devastating that these people, once upon a time, they will suffer from diabetes, they may suffer from hypertension, dyslipidemia, coronary artery disease, and other, as we have already mentioned, PCOS and metabolic syndrome, and non-alcoholic fatty liver disease, ultimately liver failure, and so many things, devastating things can happen. So we have to prevent it. NCD is the best platform by so many stakeholders to do the primary prevention program along with Bangladesh Endocrine Society and Bangladesh Diabetic Association and Government of Bangladesh. Everybody is interested to be part of this, and NCD forum can do one of the best initiative to prevent these NCDs in Bangladesh and to reduce the mortality and morbidity. I like to thank all the organizers, and especially the first national NCD conference organizers of Bangladesh, and on behalf of Bangladesh Endocrine Society, Dr. Shahzada Salim and all others who have given me the opportunity. Thank you very much. Thank you for giving me the opportunity. Thank you.
This is the end of the session. Thank you all the participants for your patient sharing.